Good morning, everyone. Thank you so much for joining us at the Public Safety Solutions for Substance Use Disorder ECHO. This is brought to you by the Center for Substance Use Training and Telementoring, also called CSTAT. My name is Andrea Roche. I'll be facilitating our conversation today. I just have some housekeeping before we get started with a really lively session. So you know these sessions are enabled for live closed captioning. If you want to view the closed captioning, go to the bottom of your Zoom window and I think over towards the right, select that show captions option. You might need to click on the three dots more menu at the bottom right corner of your screen. If you're having any trouble accessing that, just chat Echo IT directly and she'll help you out. To help with attendance, people are already doing this, but please do use the chat to enter your name, your affiliation, and your email. To access that chat feature, again, go to the bottom of your Zoom window and find that chat bubble. If you are a Be Well Texas provider, make sure you identify yourself during the session by entering your information. If you've joined by phone only, I don't think many have, but if you have, make sure you send that phone number information to the Be Well Texas team at bewelltx@uthscsa.edu, just so we know you're here and you can get credit for your attendance today. Also, if you want to review any of this content later, we're recording the session as you saw, and we make all of these available on the Be Well Texas YouTube channel after the session. And you'll also get some resources we discussed today in a post-session email. We encourage everyone to join by video for the discussion portion of the session and about the latter half of it. That said, we love that you're here. We love seeing names. We love seeing faces. We love seeing smiles. We also love seeing just black squares too. So however you're able to join us, thank you for joining us today. There are a lot of us here and that number is growing. So just to make sure everybody has opportunity to speak, please do stay muted unless you're speaking. And if there are a lot of comments happening and you want to make sure you're heard, use that reactions menu in the bottom right of your Zoom window to just raise your hand and I'll call on you. But feel free to also just unmute and speak up in moments of silence. Know that you can also share your feedback, your questions, your challenges over in the chat space. That's just another way for you to interact with the group here today. Regardless, if you're speaking up or sharing information in the chat, no protected health information is allowed in either space during these sessions. Keep an eye on that chat towards the end of the session. We'll send out a link for a post-session evaluation survey. Fill it out to give us some feedback on how these sessions are going for you and what kind of topics you would like to see covered moving forward. Also, this is your way of getting CEs for free. So right now we're approved for CEs for paramedics and any public safety professionals with a behavioral health degree. If you're interested in a different kind of CE, let us know. Fill out that survey and enter that information. Also, everybody who fills out the survey is entered into a drawing for a $30 Walmart gift card. I'm excited for today's conversation. I think we're going to have a lot of experiences brought to the table during our discussion. We're going to begin with some didactics presented by Dr. David Miramontes on withdrawal symptoms for alcohol and other drugs. And then after that, Dr. Miramontes is also going to lead us through a case and open up the room for some group discussion. There are a lot of professions represented here today, a lot of experiences. So please share your voice, share your questions, and share your challenges. You can see that didactic already starting. Dr. Miramontes is antsy to begin. Before that, I'm going to ask our hub team to introduce themselves. Jeremiah, I'll start with you.
Hi, everyone. I'm Jeremiah Golka. I'm the Executive Director of the SHIELD Training Initiative. We provide law enforcement, EMS, and criminal justice folks, as well as other first responders, with training on how to boost their effectiveness in responding to addiction, as well as making folks safer and more effective and boost the job satisfaction in the process.
Great. Thank you for joining us today. Cynthia.
Hi, my name is Cynthia Mendiola. I am a retired federal probation officer. Worked in the criminal justice setting for 34 years. I now am an independent contractor and work with a company out of Ohio to coach and train probation officers in evidence-based practices.
Very cool. Thanks for joining us. Eric.
Hi, good morning, everybody. I'm Eric Mazzio. I am a Marine Corps veteran. I am a retired police officer from Warren County, New York. And I am currently a facilitator for Solution Point Plus. We're a company that specializes in crisis intervention and de-escalation techniques.
Thank you. Andrea.
Hello, everybody. My name is Andrea Handler. I am the program coordinator for CSTAT, and welcome, everybody.
Thank you. All right, Dr. Miramontes, please do introduce yourself. You're also our didactics presenter, so take it away after that.
Sure. Hi, my name is Dr. Dave Miramontes. I'm an emergency physician by training, but I'm the physician for the San Antonio Fire Department. We do a lot of work in the substance abuse space, as well as our active 911 response, and I'm responsible for all their medical care. And I'm one of the hub members here for this participation. Hopefully you can hear me okay. Give me a thumbs up. Okay, good, great. So I'm going to go ahead and share a screen, hopefully. Okay, here we go.
Looks good. Go ahead.
All right, great. So I'm an associate professor of medicine at UT Health in San Antonio. And my full-time job is to take care of the fire department and our patients in the fire department world, both in the community paramedic space and the 911 space. I have no disclosures. I'm a state employee. You can't pay me money if you wanted to. And we're going to talk about a couple things. We're going to talk about the pathophysiology of alcohol withdrawal, which is something that our law enforcement partners, folks in probation and jail, may not have a full, haven't been read up on it real well. We're going to talk about how to analyze the dangers of alcohol or other sedative withdrawal and some treatment plans. We'll talk a little bit about the medicine so that you have an idea of what to expect when you do have to activate the medical process in order to manage, or you may need to leverage your in-house medical in the jail, in probation, or in the correctional institution to advocate for your client. So let's talk a little bit about alcohol use disorder. So I was shocked at this number, 10 to 14% in the US. And that's because that's more than 4 drinks a week for an adult, which is the new Canadian criteria. And we're all going, we're all thinking to ourselves, that's me, right? If you've had more than a couple of drinks this week, you may be into that definition. But the big thing to understand is a lot of patients are using alcohol every day. And then what happens is they stop using, or they don't use enough, they can go into withdrawals. And about half these patients, they actually do have a serious problem with withdrawals. And they know that. And by the time they are able to communicate that, usually they're in a lot of trouble. So that's why that's a big deal. So, forward. Here we go. So why alcohol? Well, alcohol's been around since the time of Jesus, right? You made water into wine. So it's a very old sedative drug that is easily available out in the world. So why do people drink? It numbs the brain and numbs the pain. So a lot of folks are using alcohol to co-treat their mental health disorder, their trauma. There's a lot of data that females with substance use disorder, over 75% of them have had some type of sexual trauma in their time. In 68% of males that have substance use disorder, there's an episode or evidence of neglect in childhood. So again, they use alcohol as a co-treatment for their mental health issue or behavioral health issue, and that's why they do that. It's inexpensive. You can panhandle for a couple hours and get enough for your whole day's alcohol, for example, in our homeless population. It's easy to obtain. You don't have to walk very far in Texas to find a place to buy alcohol. Every carry-out, drugstore, gas station, mom and pop bodega, alcohol is everywhere, okay? And they may not be hard booze, but it may be wine or beer, but still that is all available, or fortified wine. It's legal. So if you're over 21, you can buy booze, right? And unless you drive or cause a problem with a criminal behavior, you're probably going to do fine, right? It's easy to dose. So what's nice, quote unquote, about alcohol, it's very easy to self-dose yourself, right? You take a shot or you take a drink. Well, I'm not there yet. So you drink a little bit more, you get your buzz. Okay, I can settle down a little bit. I'm on my buzz plane, and you can self-medicate, keep that buzz going. It's very easy to get to that level that you need to get through the day using alcohol. It's a maladaptive response. to numb the brain, numb the pain, but it's very easy to dose. Unlike some of the other drugs where it's real easy to overdose or overshoot. Right? Our folks in the room that are law enforcement see folks that kind of overshoot their meth use that they're using. They're using meth to kind of get rid of the voices or to numb the pain or to deal with anxiety. And they kind of overshoot, get psychotic and are naked in the Walmart. And then cops are called and all kinds of drama happens. With alcohol, you don't have that much of a problem unless they're chugging, right? It's quick on, but it's gone in hours. And that's a blessing and a curse. It's a blessing because you can drink all night and then stop drinking and go to work. And then after work, start drinking again, right? So it's quick on, but it goes away. But the problem with that is if you're seriously tolerant to alcohol, you may be drinking 16, 18 beers a day. And with that much alcohol in your stomach, it's going to be pretty hard to eat meals, for example. So a lot of these alcoholics actually are malnourished. Now, they may have this big old beer belly in the front, but they're actually malnourished, protein-wise, vitamin-wise, especially with thiamine, folate, and such. So that's another problem with alcohol is that you can get full having to stay drunk and then actually get malnourished. You have calories, but you're malnourished. So what are the brain changes? So if you're using alcohol, which is a sedative, every day, every couple hours, your brain's getting sedated, okay? That's the point. That's what folks are using the alcohol for, to get rid of that anxiety, to get rid of those thoughts, to numb myself. It's a sedative, right? So what that your brain does is, oh, I'm sedate. Maybe I don't need all this negative down regulation neurotransmitters anymore. So these GABA receptors are slow down neurotransmitters. They get down regulated and they're decreased. Okay. On the other hand, your brain says, yo, you don't want to fall asleep right now. We want to stay active. I want to keep my brain working. So it upregulates some of the stimulatory neurotransmitters. Those specifically are glutamate. That's our excitatory neurotransmitters. So those are upregulated to overcome the sedation from the alcohol. Okay. And that is a chronic process that has changes in brain receptors, chain hormones, and the neurotransmitters in the brain. It changes the chemical structure of the brain over time. And when they're drinking, it increases dopamine and serotonin response. Those are good hormones, right? Those are the things that we see our kid play soccer and he scores a goal and we go, yay! And we get that dopamine burst. That's also a positive reinforcing effect for alcohol because that's helping them. So dopamine and serotonin, where have we heard those neurotransmitters before? Well, that's where our antidepressants work. That's the focus of our SSRI, serotonin reuptake inhibitors. Those drugs that we use for depression and anxiety actually raise those hormone levels up so that they're less depressed. So to a degree, the alcohol helps with that in these patients. Now, when they go off the alcohol, that all bets are off and they become depressed, suicidal, and terrible, right? So these are the actual structural changes in the brain that happen over time with folks that drink on a regular basis. All right. So here's an analogy. So here's our little pickup truck. It's got a tow rope on it, and the alcohol is hooked up to this truck. The truck's brakes are off, and he's got the gas pedal turned on, right? And the alcohol is holding him back, right? That tow rope is holding him back into normal mode. So he's just staying there, gas on, brake off. Now we cut that tow rope or we stop drinking alcohol, that truck speeds off. The pedal's down, the brakes are off, and we're at 80 miles an hour going down the freeway. That's exactly what happens in alcohol withdrawal and DTs. The brain is revved up and rocking and going forward. And that's accountable for what we're going to see in the symptoms, which I'm going to show you on the next slide. So what are you going to see when that happens? You're going to see anxiety, agitation. You might see a tremor. It looks like this. It's this hand bobble shaking, and it's worse when they put their hand out straight, because then the muscles that counteract that tremor are immobilized. So you're going to see the hand doing this. You may see their wrist doing this. It's flapping in the breeze. You're going to see diaphoresis in medical talk. That means profuse sweating for layman's. We're talking about dripping sweat. Okay. You're going to see these signs across the room, or in the drunk tank, or in the jail. Okay. You're going to see this from across the room. They're going to have nausea, vomiting, a rapid pulse. You're going to see their little temporal artery going bang, 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 bang. You're going to see maybe hallucinations or seizures. Hallucinations, those are things that they see that are not there, or they feel that aren't there. Like they're oftentimes scratching at themselves because they think there's bugs on them, for example. And these symptoms can begin in a spectrum depending on how much they drink. So it could be 6 hours after last drink, it could be 24 hours, it could be 2 days. It just depends on the individual. But the early withdrawal signs are going to be coming forth even before the blood alcohol level is low. So some of these long-term alcoholics are folks that have been drinking for a while. They may actually be having symptoms, and their blood alcohol's in the 180s or 200s still, but they're starting to withdraw. So you need to know that. So we all know that the blood alcohol level to be drunk in Texas is 0.08 or 80. Okay. So we're talking about people withdrawing or going into withdrawal symptoms when they're in the 200s, 180s. Okay. That's 3 times the level over that someone is drunk potentially. Okay. In Texas. Now, me, guy who doesn't drink very much, right? If I'm at a blood alcohol at 240, I'm going to be stumbling drunk and not getting up very much, right? But these folks may be talking to you in probation or in the jail or in court, and they're doing just fine at 200. So here are the stages. So mild alcohol withdrawal, we're going to see anxiety, tremor, insomnia, headache. Palpitations are going to feel like their heart's beating fast. They're going to have GI upset, nausea, vomiting, diarrhea. When you get into the more moderate stage, this is when things are pretty obvious. This is when the tow rope's cut and the gas is down. And so their brain's starting to react. So you're going to see it's just blood pressure going up. They're breathing faster. Their heart rate's faster. They might be a little confused. They can have a mild hyperthermia. They may be picked up by the jail nurse because they have a fever, right? And they're thinking, oh, they're sick. They got the flu. No, they're an alcohol withdrawal. You missed the boat. Okay. So this is where we can go off on the wrong path. We're not assessing our patients or clients when they come into the institution, or we meet them where they're at, and you may get off on the wrong tangent. So a lot of our alcohol withdrawal folks actually in the ER, they got brought in because they thought they had COVID. They don't have COVID. They're withdrawing. Okay. And then when we get into delirium tremens, this is truly, I want to pause for a second and you want to hear this. Delirium tremens is a life-threatening condition. This patient is in mortal risk for death. Okay. Unfortunately, we have seen this in jail. We saw this from that famous video a couple of months ago from Oklahoma, where the officers were there with a patient with delirium tremens, and the ambulance folks did not do what they were supposed to, and they made him walk to the stretcher. They tied him down, and he died on the way to the hospital. That was delirium tremens. Okay, and they knew it and didn't act upon it, unfortunately. So be aware that there are withdrawal symptoms. There are basically 4, and we'll talk about this later in the didactics. There are 4 withdrawal symptoms that are life-threatening: alcohol, sedatives, coming off seizure meds, and phenobarbital. Those 4 withdrawal symptoms are life-threatening. So methamphetamine withdrawal is uncomfortable. It's psychologically disturbing. Marijuana, if you're chronic marijuana use, it's uncomfortable. Even opioid use disorder, which we've talked about a lot, uncomfortable, not life-threatening. This one is, you can die from alcohol withdrawal. And this is an important point that we're driving home today, that you need to intervene early and intervene fast before they die on your watch. So what can we do about this medically? So in the jail, in the clinic, or in a psychiatric facility, or in the ER, if we know they're going into alcohol withdrawal and we have gotten that history, dude, how much you drink a day? Oh, I do about 40 ounces a day, okay, or 30 ounces a day. Okay, great. When'd you last drink? Last night. Well, dude, you're looking a little rough today. You're starting to get tachycardic. You got the shake. You want me to start you on some medication for withdrawal? Oh, dude, that'd be great. Can we do that? So one of the ways we can do that is using gabapentin. So this is really popular in the ER world and in correctional facilities because it's not a controlled substance, right? So it's not as much of a big deal to bring it into the institution. So gabapentin or Neuron is a medication that's used for seizures and for chronic pain, but it substitutes for alcohol in the brain. Okay. And what it does is it keeps that brain sedative effect for a brief period of time in a controlled manner until they can then detox off of this. So here's the protocol that I've been using for almost 20 years. Here's the script. Dispense number 14 gabapentin 400 milligrams. On day 1, we take 400 milligrams 3 times a day. On day 1, 2, and 3. On day 4, we cut it down to twice a day. On day 5, we cut it down to once a day. We're done. Okay. This gets good control of early alcohol withdrawal. And then we provide a slow tapered detox off. Instead of alcohol, we're using this medication to carefully and in a controlled manner detox them. This can be done in the jail, it can be done in a psychiatric facility, it can be done outpatient, it can be done wherever you come into play. Now, compared with traditional detox methods that you may be familiar with, lorazepam, otherwise known as Ativan, or Librium, right? Those are other agents that are used. So we know that compared with lorazepam, though it's a lower probability of drinking on day 1, less daytime sedation with this medication compared to the benzos, less anxiety and cravings. And the other nice thing is it's not a controlled substance. So I don't have, as a physician, I don't have to go through all this monkey business with electronic prescribing, 2-factor authentication has to be sent electronically, because all these new DEA rules. So this helps us in that process of getting the patient the drug they need in the environment that they need it with as little hassle as possible. So in the hospital, we use this CWA score, and I'm not going to go too much in depth, just so that you know that this exists, okay? The CWA score is the Clinical Institute Withdrawal Assessment for Alcohol Revised. And what we do is the nursing staff and the physician staff, when the patient comes into the hospital, they look at these different items and score them on a score, 1 to 7 or 1 to 4. And based on that, we add up the score. It's the COW score for alcohol, right? So we talked about the clinical opiate withdrawal scale. In fact, I think I gave that sedation, that lecture myself. And we look at how bad a withdrawal you are from opiates. Well, this is how bad are you in withdrawal from alcohol or the sedatives. And so we can rapidly get a score and see where we're at on the spectrum, okay? This is a reproducible, research-driven assessment tool that is, it has good interoperability between assessments. And most of the time, the nurses are doing that. And the link is in there for if you want the PDF of it. But what we do is try and look at their score. And you can look at the components: agitation, anxiety, clouding, headache, nausea, vomiting, sweats. Are they having tactile disturbance? Do they feel bugs on their skin? Do they have a tremor? Right? Is their hand doing this? Are they having visual disturbances? Like there's rats in the cell. There's rats in the cell. Or I see there's a dog in the room who's growling at me. Okay, those are those hallucinations. So you can see anybody can do that. So you don't have to be medically trained even to score this. And then based on that score, there's usually an established protocol. In the hospital, this is Dr. Easy. CWA score, click, click, use the protocol, sign. And what this does is activates this protocol. This protocol says if the nurse assesses the patient CWA less than 8, we're great, okay? Keep them on their baseline medication. If they're 8 to 19, we're getting into trouble. Let's start the Ativan process. And I'll talk about another way of doing it in the next slide. And that Ativan is IV or IM every 2 hours based on the score. And we're going to increase our assessment of the patient. So we're going to assess before we medicate, we're medicate, assess an hour and 2 hours after we medicate to see if we need more. On the other hand, if our CWA score is in the 20 to 30 range, we're in trouble. This is when the patient may need to be, instead of in the floor in the hospital, may have to go to the ICU. And they're going to need IV and every 15-minute evaluations with dosing. So if I'm dosing 2 milligrams of Ativan every 15 minutes, well, that's 8 milligrams of Ativan. Okay, that's a lot. Okay, that patient's going to have to be actively monitored in an ICU environment, perhaps. And if they're greater than 30, now we're in trouble. Now we've missed the boat. They're in delirium tremens. This patient's in a life-threatening situation. They may have to be intubated to be sedated, for example. They may be on an Ativan drip by pump. This is going to be a one-on-one nursing situation. So now we're over the line and we're in trouble. Okay, so this is where that CWA helps guide our level of therapy in the hospital. And I'm not trying to make you guys clinicians. I just want you to see how bad things can get really quickly with these patients so that you're aware and you call for help and intervene early. So another way to do this is the old-fashioned phenobarb method. Now, this is how I was trained as a resident 23 years ago. We used phenobarb orally in the detox unit, and then if we had to, we could use an injection. Phenobarb's been around since the 1800s. It's been used as a sedation, as a sleep agent. It's been used for seizure control for a very, very long time. There's a lot of experience with this drug. And actually, when I first came to UH, it was like, Dr. Miramontes, you can't use that. That's not part of our CWA protocol. And so we couldn't use it. But now it's making a comeback. And the reason why is because phenobarb is such a long-acting drug. Once you get the patient medicated, we get long-term control. So this is becoming much more popular again because it decreases nursing time, doctor time. And if we get them in control in the ER, perhaps we can send them to the corrections medic surge floor upstairs instead of having to go to the ICU. And that's good because then we don't have to send jail staff to the ICU with an extra guard, all that kind of stuff. And we can just put them in a regular detention unit in the hospital. And also this works in outpatient facilities as well. Again, this can be done orally, injection, or IV. Okay. And so what we start to use is this, in multiples of 130 milligrams. Okay. So we can load them with 130 or 260 milligrams, and then every 15 minutes dose them until we get a CWA score less than 8. And then what we can do is then put them on maintenance dose with twice a day dosing at that realm, either orally or intravenously or IM. But they need intensive monitoring while you're doing this load. But after 2 hours, they can go to the floor. They can go back to general population. They can go back to wherever, because at that point we got them loaded, they're stable, and they're doing fine. Okay, so that's a phenobarb method. And if they're in real trouble and they're in my resuscitation bay, then we're going to do IV loading. And this is if they haven't had Ativan yet, more than 4 milligrams. I can load them with a huge dose of phenobarb. Okay, this is 5 to 10 milligrams per kilogram. So for a 75 kilogram male, if such exists anymore, that's 3 vials of phenobarb at 390 milligrams. And then we can reload them again if that doesn't work. Now, these folks are probably going to go in the ICU. Okay, or they're going to have to go to a step down unit because they're going to have to be monitored with EKG, capnography, and pulse ox, because this can get them too sedated. The nice thing about phenobarb is if I get them at a level, I can draw their blood and go, oh, there's their phenobarb level. We're good. And I can titrate it based on their blood work even. But more importantly, we can titrate on their behavior and what their signs and symptoms using the CWA score that I talked about before. All right, so what about other meds? So guess what? I talked about alcohol, but the same protocol, the same situation, and the same life-threatening consequences exists for some other medications that are patients or clients or prisoners that come into our organization with. Let's say, for example, they're on Klonopin for anxiety. Klonopin's clonazepam. It's a long-acting benzodiazepine. It's often used for anxiety disorders, or they may be tacked on to a schizophrenic's treatment regime to keep them calm and sedate. But if they lost their meds 5 days ago, or they got stolen, or I couldn't get a refill because I didn't go to a doctor for my prescription because I was on a bender for the last 5 days, now they're off med. And they're going to withdraw just exactly like I described for alcohol. And it's equally as life-threatening. Okay? So that's another one. Another one is gabapentin and Neurontin. And what y'all need to know is that in the anti-narc policy that we've been doing for the last 5 years, oh, don't give them narcotics for pain. They're bad, terrible. We're actually using gabapentin. We'll load them in the operating room for their hip fracture, their shoulder surgery, their hernia surgery, or whatever. We load them on gabapentin so that we can use less narcotics for pain medication. The gabapentin inhibits the ascending pain fibers to the brain. So it's a narcotic sparing technique that we use to help decrease the use of narcotics. But you have to wean them off. So they're on it for a week after surgery, and then we do that wean therapy we talked about. 3 tabs a day, 2 tabs a day, 1 tab a day, we're good. If they just stop taking it, they can withdraw and have an early withdrawal seizure, just like alcohol, just like benzos. And then phenobarb, which we don't use very much anymore, but that can for seizure management, but that can happen as well. So it's not just about alcohol. The big 4: alcohol, benzos, which we call Ativan, Valium, Librium, Klonopin, whatever. The gabapentin anti-seizure meds, and phenobarbital. Those are all drugs that if they come in and they stop taking, they can go into this withdrawal state, which is life-threatening if it gets out of hand. All right, so what about starting alcohol use disorder treatment in the facility? So I think we had a study or a presentation in another CSTAT. We can put the link in the chat where we talked about alcohol use disorder in women. And you can start treatment in the jail as a condition for probation in the emergency department. And one of the great ways to do that is Vivitrol, is the trade name, but naltrexone can be given orally 3 times a day. Usually our folks are not really motivated about taking medications, right? If it's not coming in a bottle. So that usually doesn't work all that great, but you can use the long-acting injectable form of naltrexone. Now, you can't use this for folks that have an opioid use disorder, they're using pain meds, because you'll put them in withdrawals, obviously. But if they've been in jail for 5 days, for example, and they're ready to be discharged from jail for a court date or bond out or whatever, you can give them this medication to help keep them from using alcohol. This is a very effective treatment. We have the study shown below shows that naltrexone orally or long acting every 3 to 4 weeks actually shows fewer days of drinking per month. Now, notice it doesn't say stop drinking, but fewer days of drinking a month, fewer heavy drinking days. It reduced heavy drinking by over 51%. And coupled with group therapy, sober living, peer counselors, this can be an effective adjunct to sober living for someone who has alcohol use disorder. It may just be that extra little bump that helps them to stay in sobriety. And they may try drinking, and you know what? They don't get the serotonin dopamine rush like they used to. So they may not, it may not self-reinforce like other alcohol use disorder. This has been a very effective treatment in many circles, along with adjunctive cognitive behavioral therapy, peer coaches, sober living, getting out of the environment, 90-day residential group work, using Alcohol Anonymous or 12-step program or faith-based education. This might be a good adjunct for your client to get into, to get off alcohol and stay off alcohol. And it's not mind altering. So they can go back to work as a truck driver or a lawyer or a doctor or a nurse because the medication being used for that alcohol use disorder is not mind altering and not prohibited by whatever legal body. Okay, and so that's what I got for didactics today, and we'll have this PowerPoint in the follow-up email. Andrea Ebler is going to work the magic with that, along with a good article as reference for alcohol use disorder that we'll provide for you. And I thank you for your attention. Hopefully that wasn't too much overload. We have some word from our sponsors at Be Well Texas, and then I got tagged with a case. So because no one came forward with a case, so I got one for you. So Andrea, you're on it.
Andrea squared, we'll take it from here. Thanks. We'll steal the screen share, but while we're doing that, Megan, you got a great question in the chat. Do you want to just unmute and raise that to Dr. Miramontes?
Yeah, sorry, it's kind of wordy. I've been hearing just a lot of talk of people trying to do alcohol use disorder detox at home. And the Addiction Society has a decent little lecture series that makes it seem like it's possible. My background's ER, so I've only seen the really bad ones. So I'm kind of like, ooh, I don't know if this is something that we can do at home or not. Like, do you think that that's too dangerous to try, as long as there's like multiple check-ins and making sure they never kind of reach that psychosis or disorientation phase of it?
Yeah, so if you start them early, right? So if you're getting them in mild withdrawal, getting them on med, and you have a system of care, quote, air quotes, a system of care with that patient, which might mean twice daily check-ins. That means a peer coach. They're going to cognitive behavioral therapy. They might have to go to AA 2 meetings a day, right? And maybe their sponsor or their check-in person can check in with you. So can it be done with the telemedicine thing? Sure. If they are on drug and probably after detox or detox process, most detox patients, they're over the edge and that's not going to work, right? But is it possible? Yes. But you'd have to have a very eloquent system of care. And more importantly, a way of saying, whoa, we're in trouble here. We're going to get you back into healthcare. So yeah, do you think you can do it? Yes. Hello, we do it in the jail all the time, right? Those on the world here, we do this in jail or in all the time, right? And with various levels of success, depending on what kind of medical support you have in your jail. But yeah, it could be done. I am not a big fan of using benzos. I'm not. And I'll tell you why. Number one, it's a controlled substance. Number two, if they shoot up with opiates with benzos, they're going to stop breathing. So that's bad. Number three, I'll be selfish. It's a pain in the butt for a doctor to do controlled substance these days. So I'm not too hip to that. Number four, they can sell it. Okay. And number five, the overdose potential is there. So they're drunkicidal because they got this on board and they're drinking, then that could be a problem. So not a big benzo fan unless I really have a bunch of support, or I have eyes on the game in a detox unit or in the jail medical unit or something like that. But yeah, it could be done.
Great question. Thanks for the commentary. If you have more questions, it's going to lead right into our case conversation for today. So you can hold on to them or throw them in the chat, and we'll get to that after some announcements. I'll just ask Carly to share those slides, and I'll tell you a little bit more about some upcoming programming from CSTAT. Thank you, Carly. So the CSTAT stands for the Center for Substance Use Training and Telementoring, and it provides high quality education and best practices for responding to substance use. So CSTAT can enhance professionals' knowledge and self-efficacy to screen, to treat, and make referrals for people with substance use disorders. Visit their site online. You can engage with other resources, other training opportunities, and technical assistance opportunities. We'll throw that link in the chat in just a moment, but it's c-stat@utesca.edu. Next slide. I'm sure this isn't the first time you've seen this, but this is a really important announcement and one we're going to repeat a few times for addiction specialists and healthcare professionals. Narcan is now approved for over-the-counter sales. So be on the lookout for more information about the new guidelines, and we'll make sure to be covering this in our upcoming sessions. Next slide. So it's that time to renew our series. You've already gotten some information or some correspondence about this, so just be on the lookout in your calendar. Don't forget to add the series back to your calendar. You can do this by going into that Zoom reminder email that you get, and you have to scroll down a little bit, but it should come from noreply@zoom.us. Scroll down a little bit. Oddly hidden in that email is an add to calendar link. Make sure you click on that to import the calendar into your current calendar so that you can keep coming to these sessions. If anything ever happens and you don't see it on your calendar, just go back to the CSTAT site and you'll see how to get to the sessions from there. So we're continuing these sessions. It'll pop up on your calendar, I think, for the next year. All right, next slide. We hope to see you all at next month's Public Safety Solutions Echo. That'll be on the 8th of June. Okay, that's all I have. As Dr. Miramontes mentioned, he graciously also offered to present a case for today. But let's help him out. Let's share our experiences, let's share our questions, and let's share our challenges to what he presents today. All right, take it away, Dr. Miramontes.
All righty, so here we go. So this is a case that is a compilation of many patients that I've had to interact with, or that I've had to deal with in a performance improvement manner, perhaps. Okay. So James is our case. He's a 48-year-old lawyer. He arrives at the magistrate's office, which is our jail, city jail, at 02:30. So it's 2:30 in the morning after bars close, and police arrest him for DUI. His blood alcohol is 308, which is probably on the low side because it's been an hour or so since he got detained by the time he made it to booking, because they're waiting to tow his car and he's in the back of a patrol car. They had to wait for the DUI officer to do the magic. And so there was a little delay there. He's slurring words. He needs to assist with walking cuffs, so much so they have him cuffed in the front so they can hold him underneath his arms and bring him into the jail. He can't stand very long at the booking counter. He kind of starts to try and slip down, and so they put him in a chair. So he gets into booking, makes it through that process, and he gets put in the tank, okay, with nurses monitoring. In our place, the quote drunk tank is right across the nurse desk, so they're able to keep an eye on all the folks in there. He's sleeping overnight, snoring loudly, actually in a blissful snoring respirations. He had one episode of vomiting, and he missed breakfast. They just said, no, he's sleeping it off. We're good. Okay. And his court time was set for 1 o'clock that afternoon. And no red flags. He was just in the tank, sleeping it off, and doing okay. Doing okay. So it's lunchtime, and the officers are passing out this box lunches of sandwiches, and he ain't looking too good. Something's wrong. He's vomiting. Here, he's diaphoretic and sweaty. He's got big, large pupils, and he's yelling at a cat in the cell. Get this cat out of here. Like, why are you doing this to me? And so the jail nurse comes and evaluate him and does some vital signs. He's really pretty agitated. Actually, they had to strap him in the chair to get the vital signs. And his blood pressure is 190/92, pulse of 122, respirations are 22, pulse ox was 95%. He's looking a little rough. So on his intake, he had a history of diabetes and hypertension, and his blood sugar here is now 160. He normally takes blood pressure medicine. This is like I said, he's a lawyer. He's got health care. He's pretty squared around otherwise. This is not the same guy that came on the night before. So what do we think? Let's open it up to the group. What do we need to do next? I especially want to hear from our correctional folks, jail and cop folks, more so than medical folks. What do we think's going on with this guy based on our didactics that we had? Come on, unmute. We got to participate here. Hello, crickets. Let's go.
Well, I can start a little bit, Dr. Miramontes, at least from my experience in the probation setting, with an individual like this, who's had to go one step further, goes to court, stops the drinking. Let's say they let him out of the jail, stops the drinking, but didn't get any medical attention, and then comes to the office. I know I had a situation in that the person came in and was in serious DTs, delirium tremens. And I think it's important for probation officers to really recognize these signs, because if they don't, you have a serious emergency happening in the office.
Bingo. That's exactly where we're at with this case. And so if you look at this picture, you see the cat there? This was actually drawn by a recovering alcoholic who was drawing these pictures to describe what he was feeling and seeing and experiencing when, as much as he could remember, during alcohol withdrawal. And it's quite disturbing for the patient or the client when this happens. He is now in moderate to severe alcohol withdrawal, this case. We missed it. We missed the window to assess them at breakfast, maybe start them on some meds to temper down what was coming. So in retrospect, this 48-year-old lawyer drinks a full 750-liter bottle of vodka a day. Okay. He's now 12 hours out from alcohol use, and he is not only in withdrawal, he is slipping into acute alcoholic delirium tremens. We're there. So from our jail folks out there, I can't see the chat. What would you do if this person was in your cell block or in booking or in the tank? What would you do? I can't see the chat. Sorry.
I got a suggestion to send him to the hospital. I think, yeah, keep it coming in the chat or on mute. What would you do? What have you done? What options are available to you too in this setting?
Someone also suggests to get that Ativan going.
Oh, yeah. Okay, good. So meds. So this guy, if you had Ativan or Librium or gabapentin or phenobarb or whatever. So if you had jail medical services, this might be a time to intervene. First, take him into the medical unit, right? Not general pop, not in isolation, not in the tank. He needs to be in the medical unit where he can be monitored very closely. Another option is activate your 911 system or get him transported to jail. This is not a person I would put in the paddy wagon and take him to the hospital by law enforcement officers. I would not do that because he's in the back by himself. No one's really watching him except on the camera, and you could have a medical emergency on the way there. This is not someone to put in a patrol car to take to the hospital. Nope, don't do it. This could be a catastrophic oops. Okay, unfortunately, this guy works in ER, had it happen. Okay, guy sees it in the back of the patrol car. We go running out there with a stretcher, get him out. We have to start the process. So this is not the person to throw him in the wagon or throw him in the car, take to the hospital. It's time to call for help. So if you can't manage it in the jail with the medical unit or in the field, if this is someone you find on a welfare check, time to call for help. Call your compadres in fire and EMS, and let's get this patient squared around. So good. And then, is there anything else in the chat, Andrea?
Nope, that's it.
Okay. So in this,
but Eric, I think you wanted to chime in there.
go ahead.
Yeah, doctor, I was just thinking as you're describing this, that this just sounds all too familiar in my law enforcement experience. And I can think of a case specifically where I pulled a gentleman over in the early morning hours. I could tell pretty quickly that he was probably DWI. He admitted to me that he had drank an entire liter of Crown Royal. At that point, I was very focused on this is a crime, not this is a medical emergency. I brought him back. He was processed for DWI. And where I used to work, we kind of had this arbitrary number where as long as that person wasn't higher than a 3, that we could let them go. And so I did just that. And I recall just a couple days later, he was arrested for a similar offense by a neighboring city. And then just a couple days later, he was found deceased in his apartment.
Yeah, exactly. So everyone on this call needs to know that, remember I talked about in the didactics, alcohol changes the brain. Alcohol destroys the liver. Alcohol does malnourished. They've got all kinds of issues, blood sugar issues. This is a widespread issue for these alcoholics. And you're right. You may be seeing just the tip of the iceberg of the acute medical emergency. So you mentioned a blood alcohol 300. I could tell you I had a case in CQI just the other day where a patient presents to freestanding psychiatric unit and they blew 402. And the intake nurse says, nope, rejecting him. Nope, not taking him. It's above our cutoff. He's sick. The guy walked in on his own power, was talking, gave a full history, and he's a little slurry, but totally with the program, right? And says, yeah, I want to kill myself. I got a gun at the house. I want to shoot myself. And they sent him out for medical evaluation. So the reason why I bring this up is that patients with alcohol use disorder that are tolerant, their blood alcohols can be really, really high and they look good. So arbitrary blood alcohol levels don't help you. It's the clinical assessment of where they're at. And as that person goes down while they're in booking or wherever, and they get in the 200s, you're going to start having withdrawal symptoms. When he gets to 120, which for me would be legally drunk, he's going to be in withdrawals and in potentially delirium tremens starting. So that's a great point you make up. This is just like if in the opioid use disorder world, if you overdose and get woke up with Narcan, you're 5 times likely to be dead in a year. Alcohol use folks, they die. They die on our watch. And so we don't intervene with acute medical management during detox. We don't intervene with licensed dependency counselors, peer coaches, referral to outpatient drug and alcohol programs or medication-assisted management with some of the meds that are out there. This person could be dead. Or worse, he gets drunk and hurts somebody else with a DUI later on. So good point, Eric. All right, I'm going to continue the case real quick unless somebody else, there's in the chat or a question.
No, keep it going.
Those 5 points, will you please repeat them?
Yeah, go ahead, Swan.
Those 5 points that you mentioned, David.
It
About
was the five intervention points of this.
Yes.
Yeah, the 5 things you could do.
So we got to get them through detox, right? We have to get them hooked up with a support network, whether that be peer support, AA, a sponsor, a licensed dependency counselor. All of those things are times we could touch the patient and then get him into ongoing care, which may be he may need to get out of his environment and into residential treatment option, a 90-day program. I'm not talking about going into a facility for detox and then staying for 30 days. I'm talking about supportive housing or some type of environment where he can work on, well, what's going on? Why are you drinking? Maybe it's a behavioral health intervention. Maybe it's a psychiatric evaluation. Maybe it's getting them from being homeless. Maybe it's getting them away from the environment they're in because everybody in the house uses. All those are interventions we can take, or it may take probation or the threat of jail or the threat of bond reduction that's going to drive him into a therapeutic environment where he can get recovery and get, remember, a lot of times the alcohol is not the issue. It's a behavioral health issue. They were sexually abused as a child and he's using this medication to treat that pain, that depression. So those are all points along the continuum. He's not just a drunk. There's something going on in his life. We've got to figure that out. He's not just a drunk. There's something going on. So case continues. The jail calls 911. The medics arrive. He's agitated, uncontrollable. So they call it code gray. All the officers descend on the tank. They get this guy into cuffs. They get him restrained. The medic is using the Versed 10 milligrams. So that's a lot. Okay. When you go have your little colonoscopy and sedation, you're getting like 2 milligrams and you're stoned for an hour. This guy's getting 10, not once, twice. That's 20 milligrams of Versed. That's a lot. And we bring him the ambulance. He's sedated in cuffs because he's still but we put the cuffs in the front with leg irons in the front so we can sit him up to prevent aspiration. He's put on the monitor, pulse ox, capnography. We're measuring his CO2 as he breathes, and he's going to go to a med recess area in the emergency department. He subsequently started on the phenobarb protocol, admitted to the ICU for 2 days. He's then gone to the floor, to the detention unit, where he's maintained on phenobarb 130 twice a day for a couple of days, and then his return to general pop. He had outstanding warrants, so that's why he was not released to the care of the medical professionals, as often happens in our hospital. So he had to actually stay in custody in the unit, and then was transitioned back to the jail population, was able to get his initial hearing, and he bonded out. As condition of his bonding, he had to stay alcohol free, and he actually sought treatment in an inpatient unit in another town, actually. So a lot of times with these folks, we actually move them out of their environment. So we may send them to Dallas, or we may send them to another place far away from where he's at, so that he's not recognized by other people, maybe in the unit or by healthcare providers. Since he was a prominent lawyer in the community, he's one of those guys that's on TV, let's put it that way. Okay. And so we had to make sure that his anonymity was maintained for his own protection. So that's the case. Any other questions? We're getting close to time.
Yes, Cynthia, I saw your hand.
Yes, Dr. Miramontes, I have a question. Would the CEWA be a tool that can be used in a community supervision setting, or do individuals need to be certified to use it?
That's medical management. That's nurses, doctors, folks. That is a medical protocol, but you can use the tenets of the CEWA to recognize what we talked about, the one slide that showed the seven. So you can use that as a recognition. Hey, my client's in trouble here. Maybe I need to activate the medical system. Again, life-threatening. This is not for the faint of heart. So if you don't have active medical in the jail or in the correctional institution or in probation, this guy's going to hospital. It's okay to call 911 for this.
Thank you.
Great question. Well, I think we're coming up on time, and I want to be respectful of the end of the hour. So Jeremiah, I'm going to come to you for a wrap up of some of our key points. I want to add for one more thing in there. You had mentioned in our discussion ahead of time around the criminal justice system, maybe not coping well with relapse. And if you could also just incorporate that into some closing remarks for us.
Yeah. So remember, I told you that alcohol is used to numb the pain. So a lot of times these relapses are unmet needs. This tells you that we are not meeting this client's needs. So we have not intervened. We haven't done LCDC. We haven't done peer. We haven't figured out what his behavioral health issue. We haven't removed him from the toxic environment he's in. We as an organization shouldn't say relapse punish. We'd say we should look at ourselves and say relapse. How did we screw this up? How did we not serve this client better? And what can we do to go the next step? So a relapse to me is a cry for help. And that I look inward at me as a provider and say, how did I screw up? What could I have done differently to help serve this client and to get him down the path?
It's a really, really valuable, reflective questions for us. Jeremiah, coming to you for that wrap up at the end of the session.
Sure. Gladly, I'll wrap this up real quickly. Dr. Miramontes, thank you. You took on both parts of this today and did it excellently, as always. Just so real quick, we've been talking about so often in this program about opioid use disorder, and sometimes alcohol use disorder gets forgotten about, even though as the numbers come out to say they're each causing kind of equivalent amounts of death in the country. So a very critical issue. We've seen law enforcement agencies, police, jails, other folks throughout the system are familiar in many ways with withdrawal as an issue, but keeping it kind of acutely aware of it so that they can make sure to keep folks alive and be able to move through whatever the next steps are in the process. Also, I'll mention in my lawyer hat that it's a good way to avoid getting sued if we keep folks alive. But Eric Mazzio, you mentioned that there's this interesting tension as a police officer between seeing DWI as a crime, since it is a profound risk to public safety, yet also this moment where maybe the person needs to be connected to medical services to keep them alive in the moment, as well as down the line, reduce that person's risk to the community, right? So being able to, there are these interesting kind of arbitrary lines that are drawn, whether it's in law enforcement or in the ED or elsewhere, as Dr. Miramontes showed. And so with the suggestion of focusing on withdrawal symptoms versus blood alcohol level. So a good way to be aware of those kind of key moments of keeping someone alive. But that's also a touch point, whether they're touching law enforcement, touching in ED, an emergency department, EMS, or maybe this is popping up in say a probation, another situation, to be providing wraparound services, because as obviously as we know, we want to keep the person alive, get them healthier, and also put them in a position where they're going to avoid harm to others through such things as driving while intoxicated. A lot of different approaches to do that, a lot of ways to do it. A key is to, if the person's already justice involved, to not let moments of withdrawal or relapse kind of knock over the apple cart, and instead it's these moments to recalibrate, to make sure to learn from it, to get them to the person into a better track, perhaps a different recovery approach. And there are all sorts of approaches, whether they're what degree of at home, as Megan Clark asked about, take home approaches, or in different kind of facilities, lots of options, but keeping aware of the acute risks of death by withdrawal, really calling that to everyone's attention, and that there are a number of medical ways to address it, I think was really useful. So I learned a lot. Thank you, Dr. Miramontes. Really appreciate you doing this and the work you do.
I have nothing to add to that. Thank you so much, Jeremiah. Dr. Miramonte, again, double thanks for holding so much of this session today. And thanks to the rest of our hub team. More than all of that, thanks to all of you for continuing to show up with your questions and your experiences to these sessions. You are what make these group learning sessions. Please do check the chat for that post-session eval. We've listed it a couple of times, and we hope to see you back and in June, on June 8th. That's a Thursday at 11 a.m. Central. And I'll just plug here again, if you're experiencing any kind of thing that would qualify as a case, we want to hear from it. We want to learn from your experiences, your successes, your challenges. Let's teach each other. Thank you, everybody. Have a great, wonderful rest of your week. We'll see you in June.